Everyone, today we are going to discuss about hypertension in pregnancy. So in that we are going to discuss about pre-eclampsia and its management. Hypertension is one of the most common complications during pregnancy and contributes significantly to maternal and perinatal morbidity and mortality. It is a sign of an underlying pathology that may be pre-existing or appears for the first time during the pregnancy. That's why it is also called as toxemia of pregnancy. Blood pressure of 140 by 90 mmHg or more than an increase of 30 in systolic, 15 mmHg in diastolic blood pressure over the pre or early pregnancy level is called as hypertension during pregnancy. Incidences 6 to 8% of all pregnancies has chance of getting this hypertension. Complicates to 10 to 20% of pregnancies. Let's see pre-eclampsia. It's a multi-system disorder of unknown etiology characterized by development of hypertension to the extent of 140 by 90 mm of Hg or more with proteinuria after the 20th week in a previously normotensive or non-proteinuric woman. So, more than 140 by 90 mm of Hg and also associated with proteinuria. This occur after the 20th week. Incidences. So, that start from 5 to 15%. The incidences in primigravida is about 10% and multigravida is less, that means 5%. More common in women with chronic hypertension who has previously who is suffering with chronic hypertension. So, they have the incidences of approximately 25%. Pathophysiology. So, during normal pregnancy, it is pre-eclampsia has a complex pathophysiology. The primary cause being abnormal placentation, the uteroplacental bed. So, this defective invasion of the spiral arteries by the cytotrophoblast cells is observed during pre-eclampsia, and some immunological factor, genetical factor, renin angiotensin system, atrial natriuretic peptide, prostaglandins and neutrophils. So, this endothelial dysfunction is responsible for the clinical signs observed in the mother, and there is a hepatic impairment of the hepatic endothelium contributing to the onset of the HELP syndrome. So, HELP syndrome, that is hemolysis, elevated liver enzyme and low platelet count syndrome, and also impairment of the cerebral endothelium inducing refractory neurological disorders, which I did not included in this. Let's see the clinical features. Mild and alarming signs, symptoms we can see mild slight swelling over the ankle, and gradually the swelling may be extend to the face, abdominal wall, vulva, even the whole body. And alarming symptoms are headache, disturbed sleep, diminished urinary output, epigastric pain, some ophthalmic symptoms like blurring, scotomata, diminution of vision, or at times complete blindness. Vision usually regained within 4 to 6 weeks following the delivery. So, after the delivery again vision will be regained. Signs: abnormal weight gain, rise of blood pressure, edema can be seen. There is no manifestations of chronic cardiovascular or renal pathology in this. Pulmonary edema. Abdominal examination may reveal evidence of chronic placental insufficiency such as scanty liquor or growth retardation of the fetus. So, when there is a scanty liquor and growth retardation is observed, that means there is a placental, due to this chronic placental insufficiency, it is happening. Let's see the investigations. Urine and ophthalmoscopic examinations should be done. 24 hours urine collection for protein measurement is done, and urine becomes solid on boiling, and a few hyaline cast epithelial cells or few red cells also can be found. Ophthalmoscopic examinations in severe cases like retinal edema, constriction of arterioles, alteration of normal ration of veins, nicking the veins, and hemorrhage. Blood values and antenatal fetal monitoring. So, under blood values, serum uric acid level that will become more than 4.5 mg per dl indicates presence of preeclampsia, and blood urea levels remain normal. Abnormal coagulation profile will be shown, and raised hepatic enzyme levels can be seen. So, by doing antenatal fetal monitoring, it will be done by the clinical examination. Daily fetal count, kick count should be watched. Ultrasonography of fetal growth and liquor pockets. Cardiotocography can be seen. Umbilical artery flow, that is velocimetry, can be done. Biophysical profile can be done. Next, see the complications of preeclampsia. So, there is a during pregnancy. So, there is immediate and remote. So, under immediate, maternal complication and fetal complications will see. During pregnancy, accidental hemorrhage, oliguria, anuria, dimness of vision, even blindness, preterm labor, HELLP syndrome, cerebral hemorrhage, acute respiratory distress syndrome, and during labor, eclampsia, and during pregnancy and during labor, eclampsia can be seen. See, remember this eclampsia during labor, during pregnancy, and the puparium also can be seen. So, during labor, eclampsia and PPH, postpartum hemorrhage. In puparium, eclampsia, shock, sepsis. Fetal, IUD, intrauterine death, intrauterine growth retardation can be seen, asphyxia, and prematurity. Remote, residual hypertension, recurrent preeclampsia. Residual hypertension after the delivery, the residual hypertension means after the delivery, in usually in preeclampsia, the mother comes to the normal blood pressure level, but in severe cases like in complication, after the delivery also the woman will suffer with hypertension. So, that is residual hypertension and recurrent preeclampsia, chronic renal disease, and risk of placental abruption. So, in the next class, let us see the preeclampsia management. So, today we have discussed about the definition of pregnancy, hypertension, incidences, preeclampsia. Management will discuss in next class. If you have doubts, please contact.